We're back.
We
Hopefully
are back.
we're back.
We're always back.
Fair enough. Fair enough. So, Eric, do you want to present our topic today? Our very honey topic.
Yeah. Well, for first, unless you bill like health insurance or work in this space, you probably won't even know any of the stuff that we're talking about.
That's a good point.
Um, so we're gonna talk about the CAQH changes and why this is really important. So the CAQH is the Council for Affordable Quality Healthcare.
Mhm.
That was founded as a nonprofit, 1990s sometime. And it's a critical thing for healthcare workers, providers, billing practices. While Tiffany and I know about this, as we're counselors, we're solo practice owners and group owners, we've gone through this, there is a massive change that has happened in the last week. So they have decided to transition from a non-profit into a not nonprofit, but a for-profit. And so I want to just mention who sits on the board of directors for CAQH. I'm just going to read the names, and people can do with them what they will. Board Chair Tim Kaja, United Health Group Incorporated. Vice
AKA
Chair,
Optum.
yes. Vice Chair Susan Smith, Centene Corporation. I should probably be more confident in my pronunciation.
That's okay. You're
And
pronouncing them, and I'm like, I wouldn't know how to pronounce these, so no shade from me.
Sarah Ahmad, CAQH. Jessica Conley, Aetna, a CVS Health Company. Paul Eisenstadt, Elevance Health. Sachin Joshi, the Cigna Group. Oretta Roman, Humana Inc. So that's the board of directors right now. So you can hopefully know some of those, or maybe part of those. Those are some of the largest healthcare management systems in the United States. So the concern going on right now is that with this nonprofit becoming a for-profit, something that's very critical, you actually have to reattest and attest. You have to verify your information over and over and over. Everyone under 20, you have to go in and make sure you're up to date. Put things in, update. So there truly isn't an option if you're billing healthcare insurance to not have that account, whether you're at a nonprofit, a for-profit, a solo practice. Excuse me. You have to interact with the system. So the concern is that the access to that information being owned by those groups will be very powerful and could be monopolizing of sorts. So you have to register with them, then you're billing with them. And it ties into other concerns in the mental health space. There are a lot of different things popping up, on-demand therapy practices, apps, systems. So, and I want to be clear, I'm a huge healthcare access person, so I am not frustrated that people can get counseling. I really just want to be clear. The challenge is those models are very new and aren't as supported by maybe clinical outcomes as much as maybe financial. So that is the real fine line right now of is this because of a healthcare need for clients, or is this because of a cost saving things for these organizations? So there's a lot of concerns, and I don't even know if it's concerns. It's concerns about how this is going to play out, because this is going to be how it keeps evolving, is more large businesses getting involved in this space because they see opportunities to make money and acquire and move forward. So that's going to keep happening in every industry. But for mental health, it's kind of new. We have not typically been this is a very profitable space. During COVID, I think a lot of things exploded. And so now we're in this kind of current moment of a lot of people who used to not be interested are interested.
Mhm. Yeah, it's kind of well, not kind of. It is concerning that we're moving away from something that's nonprofit to essentially a for-profit, and putting everything in the hands of the insurance at this point. Like it is a fear that it's going to be funneled just to the VC companies that these insurance places have. I want to say created, um, if not at least they own portions of. So they're really monopolizing like the field.
Yeah. It's on the one hand, we have to find a way to make healthcare more accessible. On the other hand, I don't know if this is it. And I'm biased. Like I'm biased. Like I'm in the field, out in the world, in person, um, in the community, knowing about things going on, able to have that conversation. And it sounds silly, but here's the example I have of like Skyline Chili or Cincinnati Chili. Like you may not know anything about that if you literally aren't in the burbs of Cincinnati. Like you may not even understand what's like I'm just trying to think of a situation of like if I said, "Oh, is that more Gold Star Skyline?" Like you wouldn't understand maybe that reference if you're not really in this area because Cincinnati is weird about its chili. We don't have enough time to record that. And you might be saying, but Eric, they could just hire people in Cincinnati. But it's like that's the thing. Like, are they? Are they really? And like again, like if you're not connected to community, and so I think here's my challenge, Tiffany, is like we need communities, we need connection, and like there's so much healing in the therapy space, but around. And so I'm gonna argue that people who live in those communities that are there know what those communities need and what they want, not
Mhm.
some tech corporate office based in New York City or Chicago. I don't think they know better than like what's going on the ground. And I also don't think those companies know better than the clinician that's in the room with that person. I really don't. There's bad actors in every industry. So yeah, get them
Mhm.
out of here. But like cut that 4% that is pretty much in every field. We have worked hard. If I wanted to get paid, I wouldn't be a therapist. I would go to a different field because we are not getting paid nearly enough for someone that goes to 4 years of college and then a year or two, depending on what track you take, to get a master's degree. There are way more lucrative gigs for that. Way more lucrative. We're not here because this is the way I get paid the most. I don't want to work hard. I don't want responsibility. That's not why people become counselors. It's not.
It's definitely not.
So I guess it's just the state of mental health right now is people who don't understand it making decisions like politicians who some of them worked in the field, some of them have been adjacent to healthcare. Um, but you can make assumptions, right? Like I think this is like it just reminds me of like when we had this focus, like we need people at the table who have that lived experience. Like we need people at the table who have been a counselor, have been in a mental health space, have done these going like making decisions and advocates, not think tanks, not whatever. Like we need the people who are actually experts on this to talk about this and come up with things because Tiffany, I mean, you and I both know so many therapists, they're dumping healthcare insurance left and right. They're not going to do like you keep seeing the most skilled clinicians cut back on their access to other levels of care because they don't have to. And if that keeps happening, like you're going to just keep having this gap. There will never be enough counselors. So all we're doing is making it harder to be seen, not meeting a need.
Yeah, it's really, and that's the frustrating part where it's like you want to fight back against these big corporations and these insurance companies, but at the same time, it's like you're punishing your clients by removing your access and making like therapy in
Yeah,
general more like harder to access because you're like, well, I don't want to be punished by the insurance companies, and it's like, well, the person really getting punished is our
the
clients.
consumer. Yeah.
Yeah, like now there's less and less counselors. There's even less that are willing to deal with insurance.
Yep.
I mean, I only deal with a handful of insurances for that reason because they're a pain. But even then, like it can be really hard to like find coverage that is like even in network, and then like the wait list can be really long, and at that point like I truly wonder how many people give up because it's just it's so difficult to find a good therapist who's not burnt out, who's not working crazy hours, and who like takes insurance. It's a
Yeah.
big ask.
Yeah. Our field is under attack and it is in trouble and it is upsetting.
It is. It is unfortunately not in a great place. Not in a great place at all. And a lot of people are going to suffer. Um, and I, I, I hate to say it, but I do worry that it's going to get a lot worse before it gets any better. It is a major concern that we're going from it. The other thing too is, and you probably have more knowledge on this than me, since I you work more directly with a lot more insurance companies than I do. But I generally wonder, I lost my question. Dang it.
I see some stuff getting better. I just think you're a well enough educated person, you may just decide this is the thing. Like, you are they dealing with this in nursing? Sure. Are they dealing with some of this with surgery? Sure. Other stuff? Sure. But you're paid to deal with it. That's the problem. Like, you're paid to deal with this.
Mhm.
Like, you're getting more compensation to deal with that. Just being real.
Yeah, I mean, I don't get compensated for calling insurance and dealing with them and all of those things. I wish. Not to sound
Well,
greedy, but I wish.
and I don't even know if they're paid to deal with that. It's just they're paid better. So like even if you average out all that extra stuff, like you're getting more resources to deal with like those same exposure to trauma, same exposure to all types of things.
Hmm. Yeah.
But that's a change that's happening. So you might see more and more therapists. I know there's like some advocacy groups, like the Ohio Counseling Association is trying to come up with groups to come together as like a subcommittee and like insurance
Mhm.
action. And I know one of our colleagues runs that and is very passionate and outspoken and has been for a long time about some of the issues with
Yeah, I
healthcare
want to say
insurance.
there's been some petitions being signed, like with the healthcare changes and things of that nature. Um, I thought I saw one of our colleagues floating around a petition or something of that nature when it came to like the care source craziness that happened. And I've heard too that like, and again, you probably have more front knowledge on it than me since I don't work as close with insurance, but I heard something about Aetna cutting rates as well. Um,
Um, I've heard some things somewhere. It's like they do it state by state, so I'm not really sure.
okay.
Um, the other thing that's fun with insurance is in the contract, if you mention anything that's a specific rate or number, they'll come after you. So like I can't even like if I am, which I am, with that insurance panel, and I say this is the rate I get, I'm in violation of that contract, and they can recoup anything they've paid me.
That's
Um,
scary.
it is so. Like just I mean it wouldn't be any different, Tiffany, honestly, if we were offline. Like we're literally not able to, it's like the same, I mean, not
Right,
the same
yeah.
as HIPAA, but like we legit can't talk about it with each other or
It is
anyone.
forbidden, which
I
is
guess you could
crazy.
make
Like, I don't know, like, off the top of my head, I don't know any other company or or payer that has like that ability or that power.
yeah. And I just like there's things coming with Medicaid, like prior authorizations on certain levels of care, like IOP or so many therapy units, case management units, and like Some might believe that'll make things better. Some might believe that that'll make things better because someone's reviewing. In my personal and professional experience, it's not made it better. It's somebody not understanding like that person. There's just so many layers, and it's like this is a story I will tell here because it's not a job I'm at anymore, and it's not. But I think it tells us well. So one of the insurance companies, doesn't matter who, they give you these reviews. So you use so many codes like, hey, you have to do a clinical review. Well, this person had completed a higher level of care, but was doing really well. And they weren't meeting with a counselor anymore. And this had been like months. And I'm going to keep it like very zoomed out. But they were meeting with the case manager. And I swear this is true. So the case manager is meeting with them very infrequently. But I had to go through and sorry, you'll understand why I'm laughing in a minute. So I'm explaining this person's service history and they're asking me about their treatment. And they're like, well, where is the clinic? Why is there not more like counseling interventions happening? And I like tried to be as polite as possible. And I said, like, they're not seeing a counselor. That's why that person does not have a mental health or substance use license. They are licensed as a case manager and have the ability to do that. And I'm not kidding when I say they asked me like 5 different ways and like kept trying to ask the same. It's like they are not providing counseling services. Like we went round and round and round and round, and like they either wanted to just make the point that they didn't have a counselor and thought they should without saying that. But that is just like a very small thing of like these reviews can get whatever. They can be very critical, like, what's this, what's that, what's the progress? But again, it's some random person who doesn't know the clients, not really even maybe talking to them. They're just looking at the documentation. So yeah, can I justify something? Sure. Can I write stuff down? Sure. But Tiffany, you and I know, especially on some of the stuff we're doing, this insurance driven model is really tough. And we could get off and make a whole new episode about that. But the insurance driven model, like medically necessary, getting it, some might see things differently. It is not always this very objective scale of, yeah, okay. And so if I weigh one factor differently and that auditor does this or whatever, like you can see, well, necessary, yes, no, yes, no. And it shouldn't be like that, but genuinely, like they're trying to objectify it, but it's like how do I objectify someone's ACE score, and then why do they need more counseling and units for services now, even though they're stable? How am I? And those are the conversations that are happening in those reviews.
That's wild.
And those are the conversations that will happen more often because there is a belief that those conversations happening more often will help make sure that care is good for those clients versus what I think is perhaps maybe they're just, I mean, that's just a barrier, right? So if that's a barrier after whatever many units, you may just give that many units and stop so you don't have to deal with that step, which will be very disruptive to the client's experience. But I'm sure that will happen to a few people. Unintended consequence.
Yeah. I think it will be an unfortunate unintended consequence. That's just hard. It's hard to hear and it's hard to talk about in terms of like how much more limitation is being placed on access to mental health care when it's already so hard to.
Well, a year ago, it was all about SNAP benefits and right to work requirements and doing this and volunteering in school and this, and then you're on Medicaid, and like this and all this, and when it's rolling out this, and that's still going to happen. So they're attacking it hard. This is like a year constant war. So that's all set up. Okay. Now it's this. Now it's like, okay, well, let's go after like, it's not like the vibe is pretty clear. The message is clear about, yeah, less of that, less of this, less people, less this. We know what the number one cause of bankruptcy in the United States is. It's been very consistent. It will stay very consistent. It is healthcare. It's healthcare cost.
Yeah. The system is very broken and not helpful.
It's not. So again, we're coming in talking about CAQH and why that's going on and what it is. It's one more thing that makes this hard, one more challenge, one more hoop. I mean, Tiffany, we could go and talk to graduate students and that are about to enter our field, and like, how do you even start explaining this to someone, right? Like, I mean, we could go in and deep dive and like, why is that a thing? And da, da, da. Like,
Mm-hmm.
there's just so much. So we are a young science, a young field, but I like being seen as healthcare, but I also like us being healthcare stuff because sometimes that model is not meeting everyone's needs the same.
Mm-hmm. Yeah. And it is whenever you stop to think about like, oh, well, how will I explain this to people? It's really hard to explain it. Like, I was just explaining it to colleagues, and all more often than not, I get the, "Oh my gosh, I'm so glad I don't have to deal with that," or "Oh my gosh, like I can't imagine dealing with that," or like, "Oh my gosh, there's all these extra things we have to do in order for like people to access care. It's just not. There's no like graduate and like move straight into the field. There's just so much extra knowledge we're not taught, and then we have to like learn trial by error." That I under like it makes sense why there's one, a shortage in our field, and two, so many people who are like, I just don't want to like deal with this. It's too much, too exhausting.
Yeah, like shit. How many times have I said to you off mic that my retirement plan is to go to Costco and work at the food court and give people $1.50 hot dog combos? It's delicious.
Mm-hmm.
It's an American classic and the best deal you're gonna find probably anywhere. Maybe 99-cent Arizona tea, but I'm gonna say American classic. Even if they raised that by a cent, I'd be devastated. Just be devastated. It's amazing.
That'd be worth the price.
I mean, we're not sponsored by Costco. Very willing to be sponsored by Costco. At least I am. But I already have enough Kirkland clothes to sponsor myself. Um, all this to say, on a real note, it's just tough. It's just burnout, and I think we started this podcast kind of focusing on trauma, and we've gone through different things, and the neuro, like we've kind of evolved and going, but like there is something about this experience where it's like it's its own kind of workplace burnout trauma type of thing of okay, like what's going to happen next. And so because we're a newer field, we're more fragile to all these big waves and big changes, and we don't really have one binding thing. Like we have counselors, we have social workers, we have LMFTs, we have substance use counselors. Like we are, and we should all be on the same team, psychologists, right? Like, but to be real, like we're not all the time, and it's like we should value each other, and it's not like Team Edward, Team Jacob. It's like, how about like we're just Team Mental Health, like shit. Like it doesn't need to be, I don't know, but Tiffany, we still write it to people, no one we're close with, that's like, oh, I'm a social worker, I'm better than the counselor. Oh, I'm a counselor. It's like that blows. It just blows. It's like we have different strengths coming out of our training depending on our focus. We have different skills. Like we're different people, different. It's like, but we're on the same team. Like we don't. It's like it's just needless. Like why are we? I don't know. It's like I don't need to put you down to raise me up. I can raise you up and raise me up. There's enough space up here that all of us can be up here and feeling good about ourselves.
Mm-hmm. Yeah, don't have to like put each other down to like get quote unquote a leg up. If anything, I feel like if we were more team oriented, like we are team mental health, we probably could accomplish a lot more.
I don't know if we've ever shared on the podcast how we made the podcast or got connected. I don't know if we have. If we did, it was a long time ago.
I don't know if we have either. Thinking about it, I'm like, my memory already sucks, so I don't know.
Yeah, Tiffany and I are in a therapy group together, like with some therapists that we were supporting each other. And Tiffany was like, hey, I think I want to do a podcast. Is anyone interested? And Tiffany and I did not know each other at all,
Nope.
like at all.
Strangers.
And I don't want to say it was an interview, but I guess it was, right? Where like I met and we talked, and I was like, well, I don't know if I'm what you're looking for, or, like, I don't know, like that kind of thing. And then I think, Tiffany, you messaged me like maybe a week later and was like, like, I think we should try it. And
Do it.
from that, we figured some stuff out and got some stuff together. And yeah, so why I share that though is like, yeah, we could have been like, no, it's just my podcast, or it's mine, or it's this shared thing, and we can work together. That mutual aid thing is huge. Hey, I'm gonna water your plants while you're on vacation, no worries, got your back. Or hey, you can borrow. Like, we need more of that in society. So I bring this to say, is like, why I'm ranting on different things tonight and why I'm putting stuff together is like, this is the stuff that happens outside the therapy room that impacts the therapy room. And it like makes it why people are they're just feeling like they're dealing with all this again. So again, you don't need to worship your counselors or go. It's just all of these barriers before they ever even get in the room. We're not even talking about notes. We're not talking about this. We're not talking about EMDR versus trauma focused CBT. Like this, before any of that, this is happening, impacting them.
Yeah. It is. It's the forefront of the struggle.
So let us know if you have topics that you would like us to maybe explain, like, this is how this works as the therapy from the business, from the science. I'm thinking of ideas for what I would say to that question. But we
Don't answer the
appreciate,
question yet.
but we really, we appreciate those of you who are here with us. We're going to be looking to bring some of our favorite guests back, maybe some new guests. So Tiffany and I'm excited. I'm ecstatic because I love to talk, which is why we have a podcast. So we will be bringing some of our favorite experts, though, to speak more on their expertise or follow up. So if you do have a topic, sincerely, that you'd like to hear, like, we know a lot of different people who are experts, so we are excited to bring them in.
Yeah, we would love to hear from you guys. I'd love to answer any questions you might have. And we'll keep you guys in the loop about this ever-changing, complicated landscape that, like, just is mental health.
Mm-hmm.
Anything else before we let them turn everyone loose?
Spay and neuter your dogs and cats.
Wonderful. What is his name? It's Bob Parker.
Bob Barker.
Bob Barker.
Bob Barker.
Okay.
Yeah. Tiffany, Bob Barker is a gentleman and a scholar, and he's dead, so he can't hear you messing up his name right now. But
It's
if he
okay.
could, he would laugh.
He probably would laugh. He'd be like, come on.
Oh my God, I'm so sorry. I'm just teasing Tiffany. I'm gonna stop.
But all right. Until next time, guys.